Hello, everyone. I'm Dr. Susan Slovin. I am a genitourinary medical oncologist at the Sidney Kimmel Center for Prostate and Urologic Cancers at Memorial Sloan Kettering Cancer Center in New York. When a patient is diagnosed, multiple biopsies are done, and keep in mind that the actual prostate biopsies are really very insignificant. They're probably about 3 millimeters long by a millimeter across, and multiple biopsies are done. The average these days is 12 biopsies from different areas of the prostate. Each biopsy is washed, cut, stained, and among all of those, we evaluate each and every one for what we call a Gleason score. Now, Dr. Gleason was an actively practicing pathologist at the Mayo Clinic many years ago, and his main concern was how other institutions would evaluate each little biopsy core. There was a lack of concordance. And his thought was, well, why don't we try to maintain some level of concordance among institutions so that those prostate biopsies read at Harvard would be the same as read at University of California, San Francisco, as well as the University at Oxford or even Oshkosh. So what the goal was really to keep a level of understanding that was in agreement among institutions. Why? Because it did influence how one would proceed with care. So if you come to Memorial and instead of a Gleason 6, you have a Gleason 8, that has tremendous ramifications for how you would be treated and whether or not a particular intervention would be appropriate for you. Dr. Gleason established a grading system first based on the numbers 1 through 5. One Gleason grade 1 was actually a representation of the prostate gland with some irregularities, meaning that Gleason grade 1 looked as close to the normal architecture of prostate, the normal prostate that is, and had minimal changes. So it still looked like prostate, but there were maybe 1 or 2 cells that looked abnormal and were representative of perhaps some infiltrates by cancer. So if you think of the prostate as a glandular organ, and a gland is nothing more than a group of cells, each cell is in close apposition, not interposition, but apposition, meaning they're very close, but they are secreting little chemicals, so each one knows what the other one is doing. It sort of looks like a pearl choker, with each pearl being very close to one another. And if you look very closely, there are little knots that separate them, but they form a functional unit, and the function is to make PSA. Gleason grade 2, 3, and 4 means that more and more of those cells are losing their cohesive rearrangement. That pearl choker, nice and white pearls, are now having discolored pearls, and they don't look right. Until by the time it becomes a Gleason grade 5, there is really no resemblance to the order that you started out with. So if you want to think of it perhaps along the lines of jewelry, it's as if your pearl choker broke apart and you have sheets and sheets of these cells that are just floating around. There's no organization. And interestingly, they don't produce a lot of PSA because you need organization, or what we call differentiation, which is a housekeeping function in order to make PSA. The less organized they are, the less work they do, and they're like a bunch of hungry babies. All they want to do is eat and grow and not do any other work. The score is based on that scale of 1 through 5. The score is based on looking at the most predominant pattern that is seen on the biopsy, as well as the least predominant. So what that translates to is that for every core, a Gleason score is derived, with the highest score really being that which is used for treatment and diagnosis. So for example, if a patient, if you took a core biopsy and the most predominant pattern, the highest percentage of 90% was seen based on that 1 through 5, and it was a 5, and maybe 10% was a 1, the final score would be 6, and so on, meaning that a Gleason final score of 6 Could be a 5 plus 1, a 1 plus 5, a 4 plus 2, a 2 plus 4, or a 3 plus 3. And what that translates to is that the first number always represents the most predominant pattern. So the higher that first number, the more disorganized and potentially more aggressive this cancer could be. So even though somebody is given the fact that it's a Gleason score of 6, which is considered to be relatively midline or intermediate, nevertheless, when you look at the breakdown, that could imply that this cancer might be more biologically aggressive than originally thought. Now, what does it mean in terms of how you're treated? Well, clearly, the more aggressive cancers are considered to be Gleason 8, 9, or 10. A Gleason 8 could be a 4 plus 4, a 5 plus 3, a 3 plus 5. Gleason 9, a 4 plus 5, or a 5 plus 4. And it's sort of a no-brainer that the Gleason 10 would be a 5 plus 5. Those are considered to be more aggressive under the microscope, but I would tell you that these higher grade cancers do not always biologically behave the way they look under the microscope. We're taught that the more disorganized, the more aggressive. Nevertheless, we really don't know how they're going to behave. We know based on animal models and retrospective studies, but there are patients who, despite having these very aggressive appearing cancers, may end up having very indolent or slow growing cancers for many years before the behavior of the cancer changes. So this is actually something that we need to keep in mind. That's why we're doing genomic profiling, to try to better understand the biology. So I would not be discouraged just because somebody has a Gleason 8, 9, or 10 cancer, because really it takes time to get a sense of how this cancer is going to behave over the course of the treatment plan.